advance copy of his statement and commend him for making it at the first opportunity. We have all been horrified by the devastating scenes from West Africa, and our hearts go out to those communities confronting this threat on a daily basis. Public concern about Ebola is rising here, and it is important that people have reliable facts and regular updates. Mr. Speaker, there are parallels between the current situation and the 2009 swine flu pandemic with which I dealt. I was grateful then for the helpful approach of the then opposition, particularly the Right Honourable Member for South Cambridgeshire, and I will aim to provide him with the same. But we do have a role in scrutinising the government's approach, and I do that today in a constructive spirit. I want to echo the Secretary of State's tribute to the many NHS and Public Health England staff and the members of the armed forces who have been helping on the ground in West Africa. We have a duty to protect them in any way we can, and I want to start with the advice given to those treating people with the disease. People will be worried by reports of a second case in a health worker, this time in Dallas, and we have seen protests in Spain by clinical staff who feel a colleague has been unfairly exposed to infection. So, in the light of this, can the Secretary of State say whether he has confidence in the official advice being given to those treating the disease and whether it needs to be reviewed? Mr. Speaker, let me turn to the risk to the public here. The Secretary of State says it remains low, and the Chief Medical Officer predicts a handful of cases. A handful is not a very scientific term. So can he be more precise and give the House the full range of figures that the advisory group have considered, including the worst case scenario? I can recall agonising about whether to publish the official predictions for swine flu and the risk of worrying the public unnecessarily, but I think the public interest here lies in openness. Can the Secretary of State confirm that he is planning for the worst case scenario so that there can be no sense of complacency? Now, let me turn to the preparedness here to deal with an outbreak. On screening at point of entry, I have to say there has been some confusion. Last Thursday, the Department of Health said, quote, "Entry screening in the UK is not recommended by the World Health Organization, and there are no plans to introduce entry screening for Ebola in the UK." And screening was also ruled out by the Defence Secretary. But just 24 hours later, we were told that screening was to be introduced. Can the Secretary of State say what prompted this about turn? What official advice has he received from the Chief Medical Officer and Public Health England on entry screening? And, based on the science, do they think it is necessary? Do the arrangements he has just announced for temperature checks fully comply with that advice? As there are currently no direct flights from the affected countries, can he say exactly who will be screened? Will it be all arrivals from those affected countries? How many people a day or a week do we expect that to be? And how will they be identified? Have frontline border force staff been properly briefed about what is expected of them? And are they being trained in what to look for and in also the screening procedures? And why, Mr. Speaker, is there only partial coverage of ports of entry? What about seaports and other UK airports? On Eurostar, can he explain where the checks will take place, given that Eurostar stops at a number of places en route to London? Turning to the exercise this weekend, as the Secretary of State will know, a patient was transferred from Newcastle, where they have beds in negative pressure isolation units, to the Royal Free, where they have Trexler isolators. Is it the government's view that Ebola is better handled in Trexler beds? And in that case, is the Secretary of State satisfied that the 2 beds that the NHS has, both at the Royal Free, are sufficient? Given that in addition to the 2 Trexler beds, there are already 24 negative pressure isolation beds, making the 26 that I think he referred to, can he explain what he means by surge bed capacity? If it becomes necessary to treat Ebola cases more widely in isolation beds, can the Secretary of State say whether he is satisfied that there is adequate provision of them across England? Is he satisfied that all relevant NHS staff, including GPs, ambulance and 111 staff, know how to identify Ebola, the precautions to take in any potential presentation and the protocols for handling it? He mentioned symptoms quite a few times in his statement. Perhaps for the public watching this statement this afternoon, Will he tell the House simply what they are? On treatment, there is an experimental medication called ZMapp, which the British nurse who was successfully treated here was offered and took. Will it be standard practice to offer all affected patients ZMapp? And if so, are there sufficient supplies in the NHS at present to do that? The Secretary of State rightly focused on vaccine, and that, of course, would be the best reassurance we could give to the public. During the swine flu pandemic, huge effort went into compressing the timetable for the development of a vaccine. Is he confident that everything which can be done is being done to speed it up? Finally, Mr. Speaker, the best way to protect people here, as the Secretary of State said, is to stop Ebola at source. The UK has rightly pledged £125 million to assist Sierra Leone, but with cases doubling every 3 to 4 weeks, there is wide agreement that the response of the wider international community has been slow and inadequate. The window to halt Ebola is closing fast before it runs out of control altogether. What assessment has been made of the resilience of neighbouring countries such as Guinea and Liberia, and what help is being offered to them? The International Development Committee report was clear that the lack of proper health coverage allowed the outbreak to grow unchecked for so long. Does the Health Secretary accept that improving global health systems are the best way to prevent these outbreaks, or at least ensure that they are caught before they get out of control? Many countries support placing universal health coverage at the centre of global development, yet the UK is currently opposing such plans at the UN. Can he say a little more about the government's position on this and whether they are prepared to reconsider it in the light of recent events? Mr. Speaker, knowing from my own experience how difficult these situations are, can I assure the Secretary of State that the offer of help is genuine? But on behalf of the House, can I ask him for regular updates and maximum openness in the weeks and months to come?
Well, can I thank the Shadow Health Secretary for the constructive tone of his comments, and which I think is totally appropriate, and I am grateful for that. And I'd just like to start with what he was finishing on, actually, because I think this is the most important thing of all. The most crucial thing that we can do to protect the UK population is to deal with this disease at source and to contain it in West Africa. And that is why I'm working extremely closely with the International Development Secretary, and she's working closely with me because the role of NHS volunteers is very important in that. But he's absolutely right. The initial international response has focused on taking the 3 worst affected countries and giving them a partner country in the developed world to help them. So we're helping Sierra Leone, America's helping Liberia, and France is helping Guinea. And that has worked to a point, but we do need more help from the rest of the international community. I had a conversation earlier today with Secretary Burwell in the US Health Secretary, and we talked about the importance of having a coordinated international response for the whole of West Africa, because we won't defeat this if we operate in silos, and we need to recognise that this is a disease that doesn't recognise international boundaries. So he's absolutely right to make that point. Let me try and give him some of the information that he requested. First of all, he's absolutely right to raise the issue of the protection of health workers. This has to be our #1 priority, both here in the UK and abroad. That's why we are building a dedicated 12-bed facility that will give the highest standards of care, equivalent to NHS standards of care, in Sierra Leone for healthcare workers who are taking part in the international effort to contain the disease there. But it's also very relevant to healthcare workers here, and events in both Spain and the US will have caused great concern. I am satisfied that the official advice as to what healthcare workers is correct. The Centre for Disease Control in the US equivalent of Public Health England, believes that it was breaches in protocol that led to the infection of the US nurse that we've been seeing about on the media recently. However, they are investigating that. And that advice is always kept under review. And if that advice changes, we would, of course, respect that. But I think it is important that we follow the scientific advice that we have, but that the scientists themselves keep an open mind on the basis of new evidence as it emerges, and I know they're doing that. He talked about the full range of figures. I think that he is absolutely right to say that the way that we'll maintain public confidence in the way this is being handled is by being totally open about what we know. The reason that we stuck carefully to this formula of a handful of cases is because it is genuinely very difficult to predict an accurate exact number. And so let me say this, we wouldn't have used the formula of a handful of cases if we thought the number of cases in the next 3 months was going to reach double figures. That's why that formulation was used. But it's also important to say that was a current assessment. That assessment may change on the basis of the evidence. I will, of course, keep this House informed if it does change. He talked about screening. And it's important here to deal with, I think, a misunderstanding. So why did the policy change on Thursday? The answer is that it changed because the clinical advice from the Chief Medical Officer changed on Thursday. And her advice changed not on the basis that the risk level in the UK had changed. She still considers it to be low. But she said that we should prepare for that risk level going up. And that's why we started to put in place measures. But it isn't measures that are primarily intended to pick up people arriving in the UK displaying symptoms of Ebola. We think that most of those people should be prevented from flying in the first place. It's really designed to identify people who may be at risk within the incubation period of developing the disease so that we can track them and make sure they get access to the right medical care quickly. We think we will reach, as I mentioned, 89% of people arriving in the UK from the affected countries. We will continue to review that, and if the numbers increase and the risk level justifies, we have contingency plans to expand the screening to Birmingham and Manchester, for example. And the reason that we have included Eurostar at this early stage is because there are direct flights from those 3 countries to Paris and Brussels, from where it's easy to connect onto Eurostar. And we will use the tracking system that we are using for people who are ticketed directly through to the UK to identify where we can people who then independently go on to get a Eurostar ticket. But it's important to say that because they are changing the mode of transport in Paris and Brussels, it isn't as robust as it would be for people taking a direct flight to the UK, and we won't be able to identify everyone, which is why we need to win the support of people arriving in the UK from those countries to self-present in their own interest to give us the best possible chance of helping them if they start contracting the symptoms. I'm satisfied that both the Trexler beds and the negative isolation rooms are both safe for healthcare workers and in terms of preventing onward transmission. They use different systems. One of them is a tented system, the other is based on people wearing PPE equipment, but I am satisfied that they're both safe. I will continue to take advice on that. But it's very, very important when it comes to ambulance staff that they know that someone is a potential Ebola case so that they know to wear the PPE equipment. And it's very important because we won't be able to identify everyone who comes to the area, it comes from the affected countries, that the 111 service knows to ask people if they exhibit the symptoms of Ebola, whether they've travelled to those affected areas. What are those symptoms? The question he asked. They are essentially flu-like symptoms, but they are not dissimilar to the symptoms someone might exhibit if they had, for example, malaria. And that's why it's important to ask people's travel history and whether they've had contact with people who've had Ebola or may have had contact in order to identify the risk level. And we would like to continue using ZMAP for people who do contract in the UK, but it is subject to the international availability and the possibility of, it's not necessarily possible that we will be able to get it for everyone because there is such high international demand, but we will certainly try. And in terms of the development of a vaccine, we are doing everything we can to work with GSK to bring forward the date when a vaccine is available, indeed by looking potentially at giving indemnities if the full clinical trials haven't been conducted.